Hi, everybody. I'm Phil, one of the SU2s in Norwich. Welcome to our Hub Day. I see there's a lot of you on Teams. So what are we going to do today? We're going to give you an insight into radiology, what we do, how we fit into patient care, what our day-to-day job is. And if you're interested in applying, which I assume a lot of you are, we'll tell you a bit about the application and how best to approach it. So give you an introduction, give you an idea of what working life is like, and then Dr. Rafi is going to come and give some interesting cases, and we'll have a break. Then we'll talk through the subspecialties in radiology and a bit about academia. How does the training program work? And then a bit on the interview and the applications, which has just changed this week, and then some questions. So without further ado, I'll give over to Dr. Mohammed.
Thanks, Phil. Hi, everybody. My name is Abdullahi. I'm also one of the ST2s in radiology training here in Norwich. So I want to take this time to kind of give you an introduction about radiology and why everybody wants to be a radiologist. So I'm not sure about you guys, but my exposure to radiology was very minimal during F1, F2. I remember my only real experience was a voice on the other end of the phone. Sometimes the voice was happy, other times the voice was a bit mean or a bit moody. But apart from that, what my understanding of radiology was, I request something, it gets done, and they give me the answers. But I think that's one reason why it's a bit of an enigmatic specialty, because you've got low exposure even in med school and in your early career as well. So you're thinking you're thinking of doing radiology. Majority of people, when you ask why are you thinking radiology, they'll give you a good work-life balance, or I'm tired of the wards, I don't like patients, this sort of thing. But there's other things that you have to also look into, which is that radiology is extremely varied. I think consultants are usually like snowflakes. No two are the same. They all have very varied subspecialties and things they do that one consultant might do and another might not. The good thing about radiology training is that if you get in to ST1, you tend to stay in the same geographical area. Nobody's going to uproot you and kind of move you halfway across the country midway through your registrar training. I think the nicest people I've met are radiologists, and I think the people I've enjoyed working with the most are the fellow radiology trainees and consultants. So people tend to be quite happy and nice in the specialty. And like I said, you can really make it what you want, right? So we've got consultants who, for example, do interventional radiology, they do vascular work, but then also they do chest diagnostic radiology or HPB or breast. You can have general radiologists tend to be in DGHs that kind of have many hats that they put on, or you can be very subspecialized, just do MSK basically. There's also huge kind of opportunities to work in research. And another big reason as to why I think radiology is quite a good choice is because of the concept of supply and demand. So as modern medicine progresses, the dependence on imaging increases. I mean, it feels like some specialties can't make a decision without getting a cross-sectional imaging done for a patient. And it's just the nature of how we practice medicine now. But this brings about a few problems. One problem is, for example, 22% of the current radiology consultants will retire in the next 5 years. That's on top of already us being the third lowest consultant to patient ratio in Europe. And as you guys can see, I think the outsourcing, which tends to be called teleradiology also, has just been increasing in the last 5 years. So about 143 million was spent in 2022 outsourcing and reporting of radiological studies. It's not all sunny and happiness. There's some downsides or some challenges that come about with radiology. The first one, I think, depending on how you see it, glass half empty, glass half full, the fact that there's no ownership of patients. Some people want to have a responsibility for the patients. Other people don't. Other people want to do their bit and leave somebody else to take care of the looking after of patients on the ward. So there's no ownership. This isn't a kind of a widespread blanket thing. Some subspecialties, you might see the patient in clinic, book them in for I guess, for example, interventional radiologists will book them in for a procedure, do the procedure, and then look after them afterwards through their clinics. That does exist. But as a majority, patients that you are reporting on, or you might do biopsies or procedures or stents on, these guys tend to be under different teams. There's a bit of specialty erosion, which I think will be discussed also in later talks, but bit of turf war does exist in radiology. In some areas, radiologists do X. In other areas, there's clinicians that do this. Service pressures, like I mentioned, there's a huge demand on radiology and CTs and MRIs and plain films in a majority of hospitals throughout the country. So there's never I think a lack of work. If you make a mistake with radiology, it's written forever, it's archived, it's packed away somewhere. So that can also be a scary concept to sometimes have, but we don't want to hide from our mistakes. We want to learn from them. Teleradiology, as I showed you in the previous graph, it's become almost a normal practice in the NHS now. This is a buzzword that you often hear: AI. I think I attended the talk a couple of months before applying for radiology, and a person was talking about how we shouldn't be training any more radiologists because artificial intelligence will do the work. I think if you've actually had personal experience with AI in radiology, you'll realize that it's nowhere near where it needs to be to take over from us. I don't think there will ever be a lack. I don't think there will ever be a situation where AI does the whole job of radiologist. I think it'd be more like autopilot and pilots. I mean, you still need a pilot in the cockpit. And a bit of skill mix, which is when you see, for example, diagnostic radiographers doing a chunk of the plain film reporting. This can be sometimes a problem, but it is also a benefit for the service. But for example, as a trainee, if you want to get 3,000 plain films done, it really becomes a challenge and something that we tend to kind of tiptoe around at times. But a big thing that I think people see as a problem, especially when it comes to applying and getting into radiology, is the unfortunate competition rates, which I think were kind of put on a fast track since COVID. As you guys can see, in 2023 it was 1 to 8.77. When I applied, it was 6, and that was already a crazy thing. So I don't know where we'll go. Will it be 1 to 12 next year? God knows. But I think this is a challenge, and I think if there's a demand for radiologists, they should really increase the training numbers, I think. But it's a difficult thing because this is sort of an apprenticeship. You need consultants to trainee ratios to be in a specific range in order to maintain the quality of training. But this shouldn't put you off at all. Right, somebody's going to get the job. It could very much be you. It could very much be the other person. You just have to go ahead and try and then go for it. Like I said, it's a huge it's a huge thing that puts people off applying, but that should never be the thing. You should always try to get somebody's going to get the job. It could be you. So you're already taking the right steps by trying to learn more about the specialty. And the advantage here is that the primary bottleneck really is in ST1. Once you do get into ST1, it is a run-through program. If you want to do interventional radiology, you might have to reapply at a regional level, but then you're not going to be an ST13 waiting for a consultant to retire before you get a consultant job. There's plenty of work, so yeah, that's a good part. So what are the skills needed to be a creature of the dark? I think you need to have good clinical reasoning, fantastic communication skills, right? Because you're not only communicating with your patients, colleagues, but you need to also act as almost an intermediate between the service and the clinician. You need to be able to have good leadership and management skills, especially in MDTs where you really are the person providing the answers to the endless clinician questions. And there's a lot of because there's so much demand in radiology. I think is good that if you're able to work well under pressure, this is a very good skill required for radiology, and good hand-to-eye coordination, right? So majority of people think diagnostic radiologists don't do anything but sit at a computer. This is very incorrect, right? They have ultrasound lists, they have biopsy lists, they have all sorts where there needs to be dexterous, even in diagnostic radiology. So this is an example of a kind of a MSK consultant rota. So I'm not going to go through everything, but as you can see, there's a huge variation as to what you do, from teaching to reporting to carrying out MDTs. And usually you have one SPA or one day off. Consultants can either work or do whatever they want. So very varied. You're not kind of going to the ward and going to your clinic. There's a lot of stuff going on if you're at a consultant level. This is an example of my own trainee rota. This is a random week that I picked. Really, no 2 weeks are the exact same, but as you can see, there's also variation. I'm not just sat at a computer reporting all day. There's MDTs I attend, duty, which is when you get calls from all over the hospital, and people are trying to get their scans vetted. We have ultrasound lists. Initially, you get trained in them, and then eventually, once you pass assessments, you can go ahead and work independently with those. There's a lot of teaching. A lot of reporting. A nice mixture, kind of encompasses the whole apprenticeship aspect of radiology training. The one great thing about Norwich specifically is that we have additional teaching. So these usually happen during lunchtimes or around 8 a.m. in the morning before you might have to start your service session. And these can vary very much, right? So Monday, for example, we had an audit meeting. Tuesday, Dr. Hamid Rafi, who's going to give the talk after me, does a fantastic teaching for us where he goes through some cases. We have chest teaching, MSK teaching, neuro teaching, and it does vary week to week. But although these aren't compulsory for us to attend, a lot of us are very eager to, because it's such an invaluable learning opportunity, and something that helps us not only become good reporting radiologists and good radiologists, but also kind of helps us pass our exams later on. This is a little bit more detail about what a radiologist might do, right? So as I said before, you've got the non-patient facing portions, which is reporting scans and MRIs and nucleotide studies, nuclear medicine. But you also have your fluoroscopy and ultrasound lists, where you have fantastic, I think, in my opinion, valuable patient-facing and patient interaction. And then with the intervention point of view as well, you get to interact with your patient quite a lot, but this covers both diagnostics and IR. Vetting is what us registrars tend to do with the assistance of consultants if we need. And then we tend to give advice to our requesters. So sometimes they ask a specific imaging modality to find out a specific answer, but as we are the radiologists and the kind of specialists in imaging, we tend to give advice to our requesters about better imaging modalities and kind of justify the imaging as well. Yeah, and again, as well as all of that, we've got similar with any other training. We get to do teaching. We have to do audits, research, and work on our management skills as well. So these are a combination of or a list of kind of where we get our pictures from, if that makes sense at all. So common ones, which are plain films, radiographs, ultrasound, CT, MRI. But there's also kind of less commonly known things such as hybrid imaging, where you've got a combination of two modalities, or functional imaging, where it depends on the patient's physiology and pathophysiology to get the imaging answer. So there's many subspecialties that a radiologist can be kind of grouped into. But like I said, no two radiology consultants are alike. You will see that some of them have, for example, they do chest and cardiac, but also have a kind of a reporting session for head and neck or neuroradiology. So it is very much like a pick and mix sort of thing. If you want to do one thing, you can, and you could be very specialist focused on that, or you could be a generalist and do many things. Yeah. So how do we learn in radiology, right? So I mean, it's very different from what we did on the ward, I guess, and there's a steep learning curve. So I think the most important thing is that this is an apprenticeship. So you report, you get your reports checked. It's kind of you did this or you did this poorly, and you fix it for the next time, and you kind of pick out your weaknesses or your lacks of knowledge, or where you need to put a bit more energy into. In regards to the practical aspects, you observe and you do practical. For example, in ultrasound, you start off by doing training lists where you're not scanning as much, but you're learning how to scan. But slowly, you start to pick up those skills, and you start to practice in a supervised fashion. And pretty soon you'll be able to do it independently. It's normal. You'll make a lot of mistakes. I make a lot of mistakes. All my colleagues make a lot of mistakes. Very early stage of training. It's a very common thing. You shouldn't be discouraged by this, because it's through these mistakes in a controlled environment that we're able to learn. And on top of that, we've got our work-based assessment. So similar to what you would have in a normal training, you've got a portfolio that you need to kind of highlight your development and learning in. Our one is called Kaizen. And we've given a lot of resources on top of everything that I've just explained, such as our RITI videos. These are RITI modules. These are online learning modules, and it covers everything: anatomy, physics, pathology, all sorts, right? And then we get given also resources such as Radiopedia, StatDX. These are all online resources that we can use to further. So a lack of resources will never be a thing in radiology, because it's a specialty that's based on imaging. It's so easy to take a copy of an image, put it up on the website, and explain what it is, and then you to learn from that. Really, you don't need to physically see the patient, which is a great thing. But most importantly, being inquisitive and thinking, why does that look like this, or when does this look like that? I think that's the most important thing in radiology, and that's how you become a good radiologist. So, out of our commitment, this varies a lot depending on where you're training. This is an example of Norwich. If you're working in a DGH, some areas outsource their overnight reporting. If you've ever worked in a DGH, you know that a teleradiology company does the out-of-hours stuff. So there'll be very little out-of-hours commitment and training. But if you're working in a big hospital, a teaching hospital, then you do tend to have that. So in Norwich, consultants do 1 in 19 on calls, with slightly more frequent with IR and PEDS, because there's less consultants that are able to do those two things. Nights for registrars is approximately 1 in 20, which, I mean, if you're coming from a 1 in 3 or 1 in 2, that number just looks amazing. And then weekends, you do 1 weekend every 2 months. Again, I remember I was doing, I think, a weekend every 3 weekend. I was doing 1 weekend every 3 weeks. So again, it was really, really well welcomed. So as I said, it's highly variable and dependent on location. In ST1, we did no out of our commitments. Some places they do have out of our commitments in ST1. So yeah, just something that you have to kind of keep in mind when you're applying for a certain area. So what are some of these benefits that I haven't mentioned so far? So one great thing is, and again, this is another thing that was accelerated by COVID, I guess, the home workstations are exploded. I think almost all of our consultants have home workstations now, which means that they can do parts or all of their week and their on-call commitments from home. We've got a system here where you can just message them. It's all on one system called Soliton, which is great. Even if they're in hospital or outside of hospital, they can look at the images and give you their input. There's a growth of teleradiology, so the home reporting station can't only be used for your day job; it can also use it for teleradiology. And this means that it's a bit less physically challenging. So a consultant overnight doesn't necessarily need to come in if something kind of peculiar is seen on a scan. The images can be viewed from home, and this is something to keep in mind, especially when you become a consultant and you've got other requirements and kids and other things that you want to take care of, right? The ability to be able to work from home when needed is amazing, right? A surgeon wouldn't be able to do that. He can't operate from his house. So I just wanted to take a quick opportunity really to talk about how to make great requests when it comes to requesting your imaging. So I think even though I've only been doing the vetting process for a year, I've already seen there's a huge variability between good requests and poor requests, and I've kind of here put a range of what I would think is a good request and a bad request. So it's important to be concise, have good detail. You don't want to write 5 paragraphs for a request. Nobody's going to sit down and read that. You want to have the information that we need to be able to say, yes, this needs to happen now, this needs to happen tomorrow, or this doesn't need to happen at all, right? So having a structure, I always used to use this structure when I was a ward doctor. I would have the clinical pictures of my clinical findings, biochemistry / OBS, and any additional information depending on the request. So I'll give you an example here of a CTPA, just saying patient has chest pain and shortness of breath. isn't enough to warrant a CTPA, right? You can add a bit more detail by adding the biochem, but again, we need to know a bit more information, right? We need to have a clinical question. So even though it's obvious in the case of a CTPA, it's always good to say query CTPA, query bile obstruction, query ischemia, whatever it is, you need to ask a clinical question that we will be answering. And then the additional information added here is if the patient is on dalteparin or is anticoagulated. It's important because that kind of affects the time frame in which we scan these patients, right? So number 4 ultimately I think would be an adequate request for a CTPA, and that yeah, perfect. I've got another example here for requesting a abdo-pelvis. Patient has abdominal pain and bowels have not opened for 4 days. Query bile obstruction, query ischemia. So this is the part where it gets a bit interactive. Can you guys in the chat write what additional information would be missing from this request to make it a great request? It's a decent request now, but to make it a great request, what additional information would I need? Anybody writing at all? Does anybody want to write? EGFR, fantastic. Age is usually on the request already, but that's a very good idea. Again, lactate, perfect. That's a very good thing. In history of any abdo surgery. That is, again, see, you guys are smashing it, right? So I wish you guys would be the ones requesting regularly, right? Because it's so vomiting, fantastic. You're giving all the answers. I think you're over flooding me with these amazing answers, right? So as you said, surgical history, right? If you're thinking of bile obstruction, does he have recent or previous surgery that would give adhesions that would cause a bile obstruction? If you're thinking ischemia, really, you need the lactate, right? This bile ischemia with the normal lactate doesn't exist, right? It's very rare, right? Yep, peritonism. So abdo pain is a very wide thing, isn't it? Right? Is this yeah, exactly. You've all smashed it. So vomiting, EGFR, lactate, fantastic, smashed it. Okay, this is a good one as well. Medical history if it's got AF, which is good because is again another thing that increases the risk of mesenteric ischemia. So great. Yep. I don't even need to go into any detail. You guys have smashed it. I just want to kind of talk about a few myths in radiology. And I also thought these myths were true, right? So radiologists are sad, lonely, solitary individuals who spend all their day in dark rooms. And it's a static and boring specialty. All you're doing is scrolling. These are not at all true. I think I couldn't have anticipated how varied of a specialty this would be, right? And I've worked with some great teams in the past before becoming radiology, but I'd always considered those people just colleagues. And I think since starting in radiology and radiology training, my colleagues will almost become friends because I can come if I need help, if I'm struggling with something, if I need help with a vetting, if I'm looking at image and I'm not sure, there's always somebody that's available and extremely happy to help. Again, this is something that it's not unique to radiology, but it's abundant in radiology, right? We do spend a lot of our time in dark rooms, but it's just the nature of radiology, right? But when our MD, we go to MDTs, we go to teaching, we have our ultrasound, we have our reporting sessions, but there's also other stuff as I've shown on my rota that exists throughout the week. So it's not all spent in dark room. And I might be a bit nerdy for this, but I think radiology is the coolest specialty because think about it. All the patients that are interesting, that are very unwell, somehow always end up in a CT scanner, right? So you almost get given on a plate all the most interesting, coolest cases. And even in the short year and a half that I've been in radiology, I've seen some amazing cases. I've seen some amazing rare pathologies. And if somebody saw something a year ago, right, and saves the number, they can show you 10 years from now. They could be like, look at this. This is an example of lymphoma causing obstruction, or this is an example of a rare condition. If you understand my meaning, like it's not static because it's unlimited. And the last one, radiologists have to learn physics. That's true. That's not a myth. You have to learn physics. You have to do it in order to pass your part 1, which you'll do in the first 6 months of training. But I hadn't done physics since GCSE and I passed the exam. So any human being, I think, can probably pass that physics exam, especially with the assistance that training gives you. This is an example of, these are pictures of my colleagues who I started ST1 with, who are now ST2s, all except for Masood at the front, who isn't smiling, but the rest of everyone else seems to be smiling. And you're going to be Masood soon as well in a few minutes. But yeah, any questions at all? I'm just going to give it a few seconds to come through onto the chat coming through. Thank you. Okay, there we go. Thank you for teaching. Please could you kindly advise us on the top financial earning potential for radiology with strategies. You know, Mas'ud would be the best person. so, so I think it's a very difficult piece of information to actually gain, right? Because actually, I even before starting radiology, I'd Google this, and it's a very varied specialty, right? So what a normal consultant earns, you can find that online, right? The starting salary and what it looks like 15 years from now. But like I said, it's very varied. Some consultants do work in multiple hospitals. Some consultants will do teleradiology. And I think if I show you, I guess this graph at the bottom here kind of answers your question, right? It's a growing specialty, right? Outsourcing is increasing, so that 143 million needs to be divided somehow. If that makes sense. Any advice on giving on multiple exposure radiology point in the application? Okay, that's a very good question. Actually, it's going to be touched on a bit more by the person covering the application process. But I'll give you a quick explanation. So when I applied, I think you get top marks if you do more than 5 days of a taste a week. Now you need to do DGH and a main hospital. Contact radiology departments. So if you're in your hospital, contact your radiology department. They'll have somebody in charge of arranging these taster weeks. To get my taster week, I literally called the radiology office, like the radiology reception, and said, I'm interested in doing radiology. I want to do taster week. And somehow, some way, within like an hour, they'd already arranged the taster week for me, right? And to get the DGH kind of exposure, which I think is very important to see because it's quite different. My advice would be contact your local hospital. They'll be more than happy to have you. We have a chap with us now from Birmingham Hospital. He's a trainee in Birmingham. He's doing his taster week here with us in IL. So contact the departments. I think everybody's so happy to help you. Thanks. Is there threat artificial intelligence and radiology rules, or is it complementary? Thoughts? Okay. So this is a buzzword, and I think I've seen a lot of this on. This is my last question, by the way, because Dr. Hamid will take over. But the great thing about AI, right, is that it's a fantastic tool, but it's very much in its early age, infancy, right? Now, we use certain softwares, and I'll give you an example of a software, right? We used a software called, I forgot now, the one that did the lung nodules. Yes, it was a lung nodule detection software, right? It's great. It picks up lung nodules, but also it picks up intrapulmonary lymph nodes. I think those are. It just flags it as a node. And I remember one time I was reporting, and there was like an artifact outside of the body, completely outside of the body, and it picked that up and said that was a lung cancer, right? So just like autopilot, it's a complementary. Currently, as of now, it's complementary, right? It's not something that will take over your job, right? And ultimately, somebody needs to be responsible for the patient and the report, and that needs to be a person. Okay. It doesn't measure things properly. There's a lot of downfalls basically. So I wouldn't worry too much about AI. Now I've got Dr. Hamid here who's going to take over. So I appreciate you guys for listening to me. Thank you so much, and good luck if you apply for radiology.